Thank you for your participation in the 2021 Louisiana Virtual HPV Summit. This presentation by Melinda Wharton will concentrate on HPV vaccination, getting back on track for cancer prevention. This educational series is made possible through funding from the American Academy of Pediatrics and is brought to you by the following partners: the American Cancer Society, the Bureau of Family Health School-Based Health Centers, Louisiana AAP, Louisiana Office of Public Health Immunization Program, Louisiana Primary Care Association, Louisiana Shots for Tots Coalition, Louisiana Vaccine Alliance, LSU Health Sciences Center Dental Program, and Southeast Louisiana Area Health Education Center.
The Louisiana AAP is accredited by the Louisiana State Medical Society to provide continuing medical education for physicians. The Louisiana AAP designates this enduring material for a maximum of 0.5 AMA PRA Category 1 credits. Physicians should claim only the credit commensurate with the extent of their participation in the activity. For nurses, the 2021 HPV Summit has been approved for a total of 1.75 contact hours of nursing continuing education by Workplace Nurses, LLC. Workplace Nurses, LLC is approved as a provider of nursing continuing education by the California Board of Registered Nursing, CEP number 13654. To claim credit, nurses must view all 4 of the sessions in this series. No partial credit will be given.
This training is being given by Dr. Melinda Wharton. Dr. Wharton serves as the Director of the Immunization Services Division in the National Center for Immunization and Respiratory Diseases. She received her medical degree from Harvard Medical School and Master's in Public Health from Johns Hopkins School of Hygiene and Public Health. She completed her training in internal medicine at the University of Michigan and her infectious diseases training at the Duke University Medical Center in Durham, North Carolina. Dr. Wharton joined the CDC as an Epidemic Intelligence Service Officer in 1986 and was assigned to the Tennessee Department of Health and Environment in Nashville, Tennessee. She joined the CDC's immunization program in 1992 and since that time has held a variety of positions. From 2006 to 2013, she served as Deputy Director of the National Center for Immunization and Respiratory Diseases. In December of 2013, she became the Director of Immunization Services Division, NCIRD. She previously served as a member from 2009 to 2015 and as chair from 2012 to 2015 of the WHO's Global Advisory Committee on Vaccine Safety and a member of the FDA's Vaccines and Related Biological Products Advisory Committee from 2006 to 2020. Dr. Wharton, the stage is yours.
Thank you all for joining us to listen to these presentations about getting back on track with HPV vaccinations. The pandemic has changed so many things, has disrupted so many things, that I have to say, when all this started, I never expected disruptions in routine vaccination programs to be so profound and to have such impact. But that's where we are. And as we're thinking about kids returning to safe in-person learning, it's really important that they get caught up in routine childhood vaccinations. And the vaccines routinely recommended for 11 to 12-year-olds are particularly impacted, as I'll show you. So let's talk about HPV vaccination generally, and then what providers can do, what you can do, what everybody can do to get kids back on track. But first, some quick disclosures. I work for the Centers for Disease Control and Prevention and have no financial interest to disclose. Here are the learning objectives for this session. After this session, you should be able to identify at least one strategy that can be implemented in your practice to improve routine HPV vaccine coverage at ages 11 to 12, make an effective recommendation for HPV vaccination, and identify at least one strategy that can be implemented in your practice setting to get kids up to date who missed well-child visits due to the COVID-19 pandemic. So let's talk about increasing HPV vaccination first. Now, as you probably know, there are tens of thousands of cancers every year caused by human papillomaviruses in the United States. Of these, an estimated 33,000 could have been prevented by our current HPV vaccine if the people with those cancers had had an opportunity to be vaccinated. Now, because there's sometimes a decades-long interval between initial infection and development of the cancer, the vast majority of these cancers, but not all, actually were from infections acquired before the vaccines were available. But that's not the case now. We have safe and effective vaccines, and young people now who are vaccinated can be protected from these outcomes in the future. I'll also point out that HPV causes cancers in 6 different anatomic locations and causes cancers in both men and women. And although we think about HPV and cervical cancer most prominently, actually now there's more oropharyngeal cancers caused by cancer-causing types of HPV in men than cases of cervical cancer in women. So these are vaccines that can prevent a variety of cancers in both men and women. And there are tens of thousands of them a year, and they are now preventable by vaccination. Unfortunately, we're not really where we need to be with vaccine coverage for HPV. The National Immunization Survey tracks vaccine coverage among 13 to 17-year-olds in the United States. And looking at our most recent National Immunization Survey data from 2019, we see that we've got quite high coverage with 1 or more doses of tetanus, diphtheria, and acellular pertussis vaccine. It's actually now 90%, and coverage is almost that high for at least 1 dose of meningococcal conjugate vaccine. The coverage for HPV vaccine has lagged dramatically behind. And although it's been steadily increasing, we still have coverage that's much lower than it is for these other 2 vaccines that are recommended at the same age. And of course, every single child who got Tdap or meningococcal conjugate vaccine could have gotten HPV vaccine at the same time. Now, we might have trouble completing the series, but they should have been able to get at least 1 dose, and our coverage with at least 1 dose of HPV vaccine in 2019 was only just over 70%, and the complete series coverage was 54%, which we see in the dotted line there. So much room for improvement. We should be doing better. I'm glad we're on an upward trajectory, but we need to have been doing better. Now, one thing that we have learned about HPV vaccination is how important the provider recommendation is. So in looking at our 2018 National Immunization Survey data, parents of 78% of the adolescents who were included in the survey reported that they had received a recommendation for HPV vaccine from their provider. Of those 78%, 75% of them had their children vaccinated with HPV vaccine. Of the 22% that didn't receive a provider recommendation, fewer than half were vaccinated. The provider recommendation is really, really important. And this is what an effective provider recommendation looks like. Now that Sophia's 11, she's due for 3 vaccinations today to help protect her from meningitis, HPV cancers, and pertussis. And then you stop. You don't get into a big, long discussion about modes of transmission. You talk about HPV vaccine exactly the same way you talk about other recommended vaccines. If you're talking about HPV vaccine like it's something unusual or different or in a different category, parents will completely pick that up and they will see it the same way. So if we want HPV vaccine to be given routinely at the same time as the other two vaccines recommended at the same age, we need to talk about it the same way. And this language is very effective. And that's not to say, of course, that you don't let parents ask questions and answer those questions if they have them, but we don't need to anticipate questions and concerns and provide a lot of information that hasn't been requested, because what that just conveys is there's something unusual about this, and there's something different, and parents completely pick that up, and it will make them less likely to accept vaccination for their child. So what strategies can healthcare providers implement to improve HPV vaccine coverage? Well, probably the single most important thing is making that effective recommendation for HPV vaccination as cancer prevention for every 11 or 12-year-old patient that you see. But there's other things we recommend as well. So in multi-provider practices, assessing coverage across the practice, seeing if there's differences among providers. The providers who have higher coverage can help the ones who have lower coverage, and then develop together an office-wide strategy to improve it. That strategy needs to include everyone who works there, because even if the providers are doing everything exactly right, there could be someone else in the practice who's got concerns and who is conveying, even non-verbally, concerns about the vaccine that may be underlying all the good work that you're doing. So make sure that everybody's on board. A couple of years ago, I visited a clinic where they had implemented training for everyone. And then after the training, they asked all their staff, are you confident you can make a strong recommendation for HPV vaccine? And they actually identified someone who said no. And in that clinic, it was a large enough clinic, they were able to put that person in a different position so that her lack of confidence didn't interfere with delivery of vaccine in the practice. I know not everybody can do that, but it's really important that everybody be on board and understand that we're trying to protect kids from cancer. And then implementing system strategies to improve HPV vaccine coverage. And here's what those are: standing orders, reminder recall, having it built into the patient flow to assess coverage at every visit and prompt clinical staff to give HPV vaccine at that visit, scheduling return visits for the next dose before the patient leaves the office. Sometimes appointment systems don't go out that far, but if you can do it, it's really helpful. And then, of course, documenting the dose in the medical record and in the state's immunization information system. So let's move on to the impact of the COVID-19 pandemic on childhood vaccination. And again, this really, on my end, was completely unanticipated. Out of all the things I thought the pandemic would do, this was not on my bingo card. But what happened was, at the beginning, of course, there was this huge disruption in the delivery of ambulatory medical services between stay-at-home orders, provider offices not having the personal protective equipment they needed for infection control within their practice. It was between people being, justifiably afraid of contracting COVID. There was this massive disruption in delivery of ambulatory medical services in mid-March of last year that continued for a couple of months. Now, the healthcare providers who take care of kids are very committed to providing medical services. And they did do things like deliver vaccines in parking lots and were able to make changes to patient flow and practice so that the well child visits could be done safely. But the reality of it was there was this dramatic drop in vaccination coverage around that time that these disruptions occurred. And we saw that in the orders for the Vaccines for Children program, which is a program that my division at CDC runs. We have the contracts and systems that healthcare providers in the United States use to get vaccine for the Vaccines for Children, eligible children in their care. And what we saw at that time, just after mid-March, was this dramatic fall off in vaccine orders. This is a cumulative chart. So, you can see that sharp drop off starting after the week of March 23rd, where there was just this, over the next few weeks, this big fall off in vaccines being ordered. And by the week of April 13th, the cumulative total orders down were about 3 million. And of that, more than 400,000 were doses of measles-containing vaccine. So that was pretty concerning. Now, this shows the same type of data, but on a week-by-week basis. So instead of it being cumulative, it's looking at each week, comparing it to the comparable calendar week in 2019. And what we can see is, if you look toward the right side of the graph with the more recent weeks, on a week-by-week basis, they're pretty similar. Some are higher, some are lower than the comparison period. If you compare the orange bar, which is the current week, with which is the week in either 2020 or 2021, with 2019 in the blue bar. But if you go back to the again, that same period in early 2020, you can see there were a couple-month period where there was really a big drop-off. And as a result of that, that period that early on in the pandemic, as well as smaller reductions that have occurred over time that aren't so visible in the slide I just showed you, we have continued to accumulate a deficit. So this is going back to a cumulative curve, like the first one I showed you, and we are now deeply in deficit territory for vaccine orders for the period since the beginning of 2020 compared to the ordering pattern we saw in 2019. Overall, for VFC provider orders other than influenza vaccine were down by more than 12 million doses, and of those, 1.6 million are measles-containing vaccine. Now, there was a measles outbreak in the comparison period in 2019, so this may be this gap may be artificially large because of that. There was some more vaccine being given in 2019 than in, say, 2018, but the difference is not nearly big enough to account for this. And we really do have a reduction in orders for measles-containing vaccine, which of course is very concerning if we start thinking about travel picking up, kids going back to school, not having kids up to date on measles vaccine. That's really bad. And there are other data which show not totally consistently, but pretty consistently what looks like a slower recovery on the public sector side compared with the private sector. So if we look at where we are now with our VFC provider orders, they're not the same for all the vaccines. And I think this really reflects that both parents and providers have prioritized providing care to the younger children, which was something that we recommended at the beginning of the pandemic. And so, for rotavirus vaccine, which is just 2 or 3 doses given in the first 6 months of life, that's down just under 6%. Pneumococcal conjugate vaccine, which is 4 doses with the last dose in the second year of life, down by about 8%. DTAP containing vaccines, 5 doses with the last dose at 4 to 6 years, down almost 9%. Compare that with these vaccines routinely recommended 11 to 12. Tdap down 17%, HPV down 18%, and meningococcal conjugate vaccine down almost 14%. These are much larger gaps than we see for these vaccines administered for young children. And then, of course, measles-containing vaccines down by more than 18%. And again, that's probably exaggerated a little bit because of the comparison period we're using, but we still think there's a really substantial reduction that puts kids at risk. So, getting kids back in school is really important. We all want that to happen. This is from an article I saw in the Washington Post back in February. And the article was about a public school in the District of Columbia that had done a really good job of doing outreach to families, helping to get them comfortable with having their kids come back to in-person learning. And so it really was a story about a success. But embedded in that story were these couple of sentences I put on the slide. Even though The parents had been persuaded that it was safe for their children to return to school. Many were unable to come back because they lacked the immunizations required to come back to school. And that's what we're dealing with, with so many kids having been learning virtually, just kids are not up to date. So there is a need for catch-up vaccination urgently as we plan for safe return to in-person school. And we know that many school-age children missed recommended vaccines over the last year due to the disruptions associated with COVID-19. And we're especially concerned about the gaps for measles vaccine and the vaccines recommended for routinely at 11 to 12, including HPV vaccine. Of course, schools had other things they were dealing with last year, and there may have not been a focus on compliance with school vaccination requirements during the 2020-2021 school year, regardless of who was responsible for compliance, whether it was the school system or local public health. And it's really important that we get kids caught up on the vaccine doses they missed so that they can safely return to in-person learning. That's what we all want. And of course, now that COVID-19 vaccines is available for the younger adolescents, we still need to assure that catch-up efforts continue for the routinely recommended vaccines. And the thing is, we know what needs to be done. We just need to do it. So healthcare systems and healthcare providers should figure out who missed a dose and contact those families to schedule appointments, provide prompts to clinicians when those children are being seen for other reasons to make sure that vaccines are delivered that are due or overdue, and continue to to let families know what precautions are in place for safe delivery of in-person services. People do continue to have some concerns about this, and so let folks know what's being done to make it safe to come into the office. And healthcare provider organizations like the AAP should be encouraging members to identify and follow up with families whose children have missed doses to get appointments scheduled. The schools and local and state government agencies can send reminders to families about school immunization requirements, follow up with families whose children are not in compliance with requirements to encourage compliance. We're not trying to get kids excluded from school. We're trying to get them vaccinated so they can be safe back in school. And then use the state's IIS's reminder recall capacity to notify families whose children have fallen behind on vaccines. And of course, we all should communicate directly to families the importance of well-child visits and getting caught up on any recommended vaccines that were missed. So I really appreciate you all taking the time to listen to these presentations and think about what you can do in your work setting to both get kids up to date on the vaccines they missed, but also have systems in place so that we can assure that kids have an opportunity to get all the recommended vaccines at the appropriate time and don't fall behind, because it's really important that kids are protected from the diseases that we can protect them from. I think if there's anything that we've learned this last year, it's how important vaccines are when we're dealing with communicable diseases. And these are diseases we can prevent. They're recommended for young children. And I really appreciate everything that you can do to help us get kids back on track. Thank you.
Thank you for watching today's presentation. We hope that it was educational and gives you ideas for implementation. After viewing all the presentations in the series, please complete an evaluation feedback form by scanning the QR code you see on your screen or going to www.surveymonkey.com/r/2021 LA-HPV Summit. Your feedback is valuable as we continue to plan future events. In addition, you will be asked for your mailing address. As a participant in the series, you will receive a copy of all presentations on a flash drive, in addition to several other resources. We hope this has been helpful to you. Should you have additional questions or want additional information, please reach out to the Louisiana AAP either by calling 225
379-7923 or emailing admin@laAAP.org. Thank you again.